Hello again, friends. This will be a talk on some of the benign lesions of the cervix. So we're working our way up the female genital tract. We talked about the vulva, we talked about the vagina, and now we're going to talk about the cervix. We will start with a vignette. A 32-year-old woman presents to your clinic complaining of spotting between menstrual cycles. This has been going on for about 3 months, and there is no apparent pattern to when the spotting happens. She does, however, mention that she thinks it is worse after she has intercourse. She is G1P1 and has no history of sexually transmitted infection. Her menstrual cycles occur regularly in 28-day intervals, and she says she has an average, quote-unquote, average flow. She says she uses about 5 or 6 pads per cycle. She is monogamous with her boyfriend of 3 years. Her most recent pap smear was last year and was unremarkable. Speculum examination reveals a cherry red growth extending from the internal cervix into the vaginal canal. On manual examination, it is appreciated as a mobile mass of approximately 1 centimeter diameter. And here's what you see on your speculum examination. So this is magnified. Not sure if this is done a speculum examination or colposcopy, but either way, this is what you see. All right, we're going to talk about this in greater detail, but this is a classic presentation of a cervical polyp. These are pretty common. They most commonly occur in women who have had children, and the most common age is older but not quite yet menopausal. So I would say women in their 40s, but it can occur in any woman. Usually it's going to be a woman, however, who is still in her fertile period, maybe a little bit later on. But it doesn't really matter. It can happen in any woman. The most common presentation of a cervical polyp is intramenstrual spotting. Now, there are all sorts of causes of bleeding in between periods, but this is one of the more common ones. So the classic presentation of a cervical polyp, because these are small and a woman can't feel them, they don't cause pressure or anything. They typically are no more than a couple centimeters in diameter at the most. Usually they're only millimeters to a centimeter, most commonly. So typically a woman doesn't feel it. Usually it's going to present as spotting between menstrual cycles. And classically it is going to be aggravated by intercourse because, as you can see, these are well vascularized. And as they extend into the vaginal canal, they can become, trauma or intercourse can cause them to bleed. So that is a classic presentation. Anytime you get a woman with a history of bleeding, of intramenstrual bleeding, you want to know, are your periods regular? Because it's possible to have irregular menstrual cycles where you're getting a menstrual cycle after 3 weeks, and then you get another one 5 weeks later, and then your next one's 4 weeks later, and you want to get an idea of whether that's happening. We see in her that she has regular menstrual cycles. She gets predictable bleeding every 28 days. However, she's also getting this spotting in between those cycles, and it's spotting. It's not as bad as when she has her menstrual cycles. It's just a small bit of blood, and like we said, it's worse during intercourse. The giveaway here is your examination. So these cervical polyps, they grow in the endocervix and they protrude out. Typically they'll protrude outwards into the vaginal canal, and they just look like these little arms that kind of come out and show their face in the vaginal canal. Typically they're pedunculated and they're pretty easy to remove. As we're going to see, we remove these because of the bleeding. Not so much that the bleeding is a problem. They don't bleed that much to where they would cause anemia or anything, but we remove them because there are other causes of bleeding, more problematic causes of bleeding, like endometrial cancer, for instance, that this can mask. Well, the last thing we want to do is to just leave it there and say, oh, it's just you're bleeding, it's just because of cervical polyp. Well, yes, but what if she has something else more malignant or more problematic that's bleeding, and then we just say, oh, it's bleeding due to the cervical polyp. We don't want that to happen. We want to remove this just because it can mask other causes. So in this case, typically we will remove the cervical polyp, but it is elective. We don't have to, but it's common practice. We're going to talk about this in a little bit. All right, we'll start with cervical cysts. The Nabothian cyst is probably the most likely to come up on the exam because they're common. We'll go into a little bit greater detail on cervical polyps, which we already talked about. We'll talk about cervical fibroids and then cervical stenosis, which has some OB implications. So this is the cervix. We know there's the vagina down here, and then the cervix is approximately 4 to 5 centimeters in length. That's going to vary from woman to woman, but usually 4 to 5 centimeters. If it's short, that can cause OB problems. Usually around less than 2.5 centimeters or shorter, that can cause some serious problems. Now the cervix will change, especially later on in pregnancy, 36, 38 weeks. It shortens and effaces, but in a non-pregnant woman, the average length is 4 to 5 centimeters. The average diameter is approximately 8 millimeters to 1 centimeter. And that diameter can be narrowed in cervical stenosis. And the cervix has an external orifice or external os. That's what we see visible on speculum examination. And then there's also an internal orifice, which leads then into the body of the uterus. So this is just what you would see and face when you're looking at the vagina, and this is the cervix here. Note that there's a difference in color. What this represents is the squamal columnar junction, or the transition zone. What you have here is a histologic change, where you're going from squamous tissue of the vagina to the columnar tissue of the cervix. And this is important because it is at this transition zone where cervical cancer typically develops. When you're doing a pap smear, you want to make sure that you're getting tissue from around this transition zone, both of the ectocervix out here and the endocervix in here. All right, so cervical cysts, the majority of them are what are known as Nabothian cysts. Nabothian cysts are dilated retention cysts. They're a rounded elevation of columnar and squamous epithelium, and they contain mucus. So you have columnar epithelial cells which exist within the cervix, usually in the endocervix, and they will secrete mucus. If they get blocked, then you can form these cysts. Typically, Nabothian cysts will form in the endocervical area. However, they can form in the proximal ectocervix as well. They appear as smooth, clear, whitish or yellowish, rounded elevations, and they are typically around the cervical os. So they're usually in this area right here. However, they can extend outward into the proximal ectocervix as well. They contain mucus, as mentioned, but they are generally no more than 1 centimeter in diameter. So as you can imagine, they're not very consequential. If they get big enough to where they interfere with getting a pap smear, because remember they are in that sort of transition zone area, then in that case you can treat them, and all you're going to do is just open and drain them with a biopsy forceps. However, in most cases they're not going to necessitate any kind of treatment. They can get bigger with menstruation. Why? Because you're just secreting more mucus during menstruation, and so they can get bigger and then they kind of shrink down a little bit afterwards. So that's the Nabothian cyst. I'll show you a picture of that in a little bit. Some other cysts. There is the mesonephric cyst. This is congenital. This is a remnant of the Wolffian duct. This is the cervical equivalent of the Gartner cyst that we saw in the vagina. It's a remnant of the Wolffian duct. Remember, the Wolffian duct in a female should involute. That's part of what becomes the male reproductive tract, everything from the testes to the prostate, so vas deferens, seminal vesicles, and so forth. This is going to involute in a woman, but if it doesn't involute all the way, you can have these remnants, and they then form these cysts. And typically, compared to the Nabothian cysts, these mesonephric cysts are deeper in the cervical stroma, and they are more distal. They're going to be on the ectocervix, and of course, like we've mentioned before, they can also form further out in the vagina, in which case they're considered a Gartner's duct cyst. I wouldn't worry about differentiating the two, but what I would keep in mind is that these Wolffian remnants can form cysts in various different areas. You can also have endometriosis, which manifests on the cervix. These tend to appear reddish to purple in color. Really, the best way to differentiate this, apart from how they appear, the Nabothian cysts are usually going to be whitish or yellowish. Endometriosis, quote-unquote, cysts are going to be darker in color, reddish or purple. But with endometriosis, typically these women will have symptoms of endometriosis elsewhere. They'll have cyclical pelvic pain, which peaks in the late luteal phase, usually around 1 to 2 days before menses. They typically have dysmenorrhea, dyspareunia, abnormal bleeding. They may have a history of infertility. If you do a rectovaginal exam, a lot of times you'll be able to feel that uterosacral nodularity. And so there's various ways that you can appreciate endometriosis apart from the presence of these endometriosis cysts. But this is a manifestation of endometriosis. Sometimes you'll be able to see that uterine tissue, that endometrial tissue on the cervix, and they will typically be red to purple in appearance. So if you suspect endometrial tissue on the cervix, look for a history that's consistent with endometriosis, because they'll typically have it. Cervical cysts, as a rule, do not need to be removed unless they're symptomatic or they interfere with Pap testing. Very rarely are they symptomatic. Typically the problem is, and usually it's with these Nabothian cysts, that they interfere with Pap testing. So this is a Nabothian cyst. See if you can find it. It's right up here at the 11 o'clock position. Note this sort of yellow whitish appearance right around the transition zone. This is looking a lot closer up. You can see there are several Nabothian cysts sort of right around the transition zone. Transition zone is right here, and here's our big Nabothian cyst. Whitish to yellow in appearance, they're filled with mucus. Don't need to remove it unless it interferes with Pap testing, and they have to get pretty big to interfere with Pap testing. Cervical polyps, we talked about this. These are asymptomatic and almost always benign. Only 1% show malignant changes. And because these are almost always asymptomatic, very rarely do they present with symptoms, but when they do present, then they will usually be postcoital or intermenstrual bleeding. But most of the time, the woman will not have any symptoms, and you'll be going in to do a Pap smear, for instance, and you'll note the cervical polyp. Most of these are asymptomatic. Okay, so I don't want you to get the wrong idea, because we had this vignette and we saw the cervical polyp with a patient who's presenting with intermenstrual bleeding, that these are always symptomatic. They're not. Most of the time they are asymptomatic. But when they do present, they will typically be intermenstrual or postcoital bleeding. And it is an important differential for that symptom. But most commonly, they are detected on cervical exam that's performed for other reasons. We do routinely remove these when we do detect them, like I said, because you don't want the bleeding from these polyps to mask other sources of bleeding, such as cervical cancer, fibroids, adenomyosis, endometrial polyps, endometrial hyperplasia, endometrial cancer. All of those things can cause bleeding, and they're a little bit more problematic in etiology, regardless of whether they're benign or malignant. So we're going to remove these. We prefer to remove these when we detect them. But it's not because of the malignant potential, even though, yes, 1% are malignant. That's not really why we're removing them. We're more concerned about the bleeding masking other sources of bleeding. So if we remove these and the bleeding stops, then we're happy with that because it shows that the bleeding was from the polyp and not from something else. However, if we remove them and the bleeding continues, then we may look for other possible sources depending on the woman's age. A lot of times what we'll do also before we remove it is to do a pap smear as well, just because, one, we're already in there, two, cervical polyps may be confused with cervical cancer. However, the astute gynecologist should be able to detect the two of them with pretty good accuracy, just because of the appearance, the sort of pedunculated mass that comes out of the endocervix and into the vaginal canal. All right, so cervical polyps. And this is an appearance here. Again, these can be sessile or pedunculated. If they're pedunculated, it's pretty easy to remove them in an office setting. If they're sessile or if they're larger, then in a lot of cases you'll have to put them in the OR and do some anesthesia because it's just a little bit more difficult to remove. You'll have to use electrocautery. So here's one, and then we have another one here. Notice how this is just sort of protruding out into the vaginal canal. Cervical fibroids. Histologically, these are identical to those found in the uterus. These are leiomyomas. Most commonly, fibroids are found in the uterus. However, they can either form in the uterus and then protrude into the cervix, or they can actually arise in the cervix itself. Now, unlike the cervical polyps, these are intramural, for lack of better words. So they don't form on the outer part of the tissue. They form from underneath the superficial layer of the cervix. And so they appear more like a mass inside the tissue. That's really what a fibroid is. And so they're going to appear a little different. It'll be more like a tissue bulge into the cervical canal. So they're a little bit different in appearance. We're going to see a picture of that. These can also bleed. So really the symptoms are going to depend on size, but even the smaller ones can cause some bleeding. Larger ones can cause mass effects. You can get dyspareunia, bladder or rectal pressure, and of course they can lead to OB complications because they obstruct the cervical canal. So they can cause malpresentation, they can interfere with dilation of the cervix during labor, they can cause hemorrhage, and of course obstruction of the birth canal, which can lead to problems in the second stage of labor and beyond. For diagnosis, typically you will suspect this on bimanual exam. However, it can be confirmed with sonography and certainly with hysteroscopy. You don't need to remove these. You'll want to screen for cervical cancer just because they can appear similar in some cases. But again, the astute gynecologist is going to know the difference typically just by clinical examination. But as a rule, we screen for cervical cancer. That'll almost always come back negative because these are pretty easy to tell apart. And then if they're symptomatic, you can remove them. Otherwise, you can just leave them be. I would suspect if, certainly if they're symptomatic, but if the woman is planning on becoming pregnant in the future, then you may want to remove it just to prevent some of the OB complications. But if the woman's 40 years old, she doesn't plan on having any kids, and it's asymptomatic, you can just leave it be and just monitor it with her annual gynecologic visits. So this is a sonogram. We're looking at the cervix here. This is the cervical canal. coming outwards, and this is you have fibroids actually on either side. So here's a posterior fibroid and an anterior fibroid, and these are quite large. So how you go about managing this really just depends on the woman. If the woman is past childbearing age or she doesn't want to have any more kids and she's got significant symptoms, you might just go ahead and do a hysterectomy. But otherwise, they can be removed while preserving childbearing potential. So here's an example of the cervical fibroid. Note that it looks quite different. This is on hysteroscopy, by the way. Note that it looks quite different from the cervical polyp, which is this sort of pedunculated reddish lesion. This is inside the tissue, intramural, in the muscular layer, and it kind of protrudes, bulges the tissue outwards. Okay, finally we'll talk about cervical stenosis. This presents obviously much different compared to the others. Cervical stenosis is a narrowing or obliteration, complete obliteration of the cervical canal. It can be congenital or it can be acquired. So when it's congenital, it's typically due to segmental Müllerian hypoplasia. Now, when we talked about some of the problems that go on in the vagina, one of the things we talked about was MRKH, Meyer-Rokitansky-Kuster-Hauser syndrome, or vaginal agenesis, and that's due to a failure of development of the Müllerian ducts. Now, you can have a problem where certain segments of the Müllerian ducts fail to develop, whereas other parts do develop properly. And in that case, you're going to have problems in certain parts of the genital tract, from the fallopian tubes down to the vagina, but not in others. And so it is possible that the part of the Müllerian duct that goes on to form the cervix can be hypoplastic, whereas the parts that form the uterus and the fallopian tubes and the vagina are fine. And that can happen anywhere. So this is called segmental Müllerian hypoplasia, and it really is just the same exact process going on as if you were to have the entirety of the Müllerian ducts to not form properly. In this case, it's just segments. And that can happen anywhere, but if it happens in the cervix, that's what causes congenital cervical stenosis. So in that case, you would have an obliterated cervix, but the vagina and the uterus and the fallopian tubes will all be normal. Acquired causes are much more common. This can include causes such as trauma, obstetrical trauma. It can be post-operative, so LEEP, conization, D&C procedures. All of this can lead to scar formation, which can then lead to a narrower cervix. Remember, the average diameter of the cervix in a woman who is not pregnant or in labor is approximately 8 millimeters to 1 centimeter. So if it gets narrower than that, obviously that can lead to problems. We'll talk about what those problems can be. Infection, cervicitis, obviously can lead to scar formation, radiation, and then atrophy. Typically, atrophy is not so much a problem because when does this atrophy occur? It occurs postmenopausally. And after menopause, women are not having periods, and we're going to see that the most common problem that comes from cervical stenosis is either due to obstetrical complications or due to problems with menstruation. So the symptoms: mild cervical stenosis, provided that there is a competent enough outflow tract for menstruation. Mild cervical stenosis is asymptomatic and really does not cause any problems other than obstetrical complications. Now, if the outflow tract is narrowed enough or completely obliterated, then you are not going to have an outflow tract for menstruation, and this can present as cryptomenorrhea. We talked about cryptomenorrhea when we talked about some of the disorders of the vagina, and what cryptomenorrhea is this just an inability to expel the menstrual contents, and so this will Cryptomenorrhea is just a way of describing that you're having menstrual cycles, you're having periods, but you don't know it because you can't get rid of the contents. And so a woman will say, I'm not having my periods because there's no blood coming out of me every month. Now what's going to happen here is that those contents are going to build up and you get hematometria. And over time, this can distend the uterus and you can get a midline mass, a midline pelvic mass. And that is one way that this can present. This can also cause pain. That's going to be secondary dysmenorrhea. We know the cause. It can cause infertility if the cervical canal is stenosed enough. You're not going to be able to get sperm up the cervix and into the uterus and fallopian tubes. And as mentioned, this can cause OB complications, which include cervical dystocia, prolonged first stage of labor. How do we diagnose this? Well, of course, history and symptoms are useful. Do remember, though, very mild cervical stenosis is asymptomatic. So a lot of these cases you're not even going to know. But severe cervical stenosis, you can go ahead and attempt to diagnose this. Pretty easy. You just take a small probe, 1 or 2 millimeters, insert it into attempt to insert it through the cervix into the uterine cavity. If you're unable to pass it into the uterine cavity, boom, you got a diagnosis of cervical stenosis. Note that you're using a very, very, very small probe. Cervical stenosis typically has to be pretty considerable in order for you to even get to the point where you feel like you need to try diagnosing it. Because if it's just, let's say that the cervix is 4 millimeters rather than the normal 8 millimeters, it's still not going to be enough to cause symptoms. It has to usually get pretty narrow, less than 1 millimeter, in order for symptoms to develop. So inability to pass a 1 to 2 millimeter probe into the uterine cavity is diagnostic. Okay, what these are here are Hagar probes, and then these are dilators. And these here on the right are called Pratt dilators. You can use either of them, but this is how we manage cervical stenosis. We do cervical dilation. A lot of times you don't need to do anything for this if there's no symptoms, but if there are symptoms, particularly cryptomenorrhea, you'll use these probes. And the way you go about this, a lot of times you'll have the woman come in. You want to make sure that you exclude things like pregnancy or infection, and you'll have the woman come in and you'll insert these probes gradually and sort of graduate up to the larger probe. So you'll insert one probe, you'll remove it, you'll insert another probe, remove it, and gradually dilate the cervix. A lot of times then also you'll stick a catheter in there to for a couple days afterwards to help facilitate the healing process so that it remains competent. I think that's all I wanted to. Okay. A couple other things. You can use misoprostol. Of course, you want to make sure the woman's not pregnant, but you can use misoprostol. That can help with the procedure. You can also use intracervical vasopressin. That can also facilitate the procedure. It's been shown that if you use that, it decreases the force necessary for cervical dilation. So these are the probes you use. Management for cervical stenosis is gentle cervical dilation using graduated probes. And that's all I wanted to talk about as far as benign disorders of the cervix. Any questions, go ahead and write me a note below.